what is a QALY? It is a common currency. It combines two things we care about: living asterisk longer asterisk and living asterisk better asterisk. To calculate it, we assign a utility value to a state of health. Perfect health is 1.0. Death is 0.0. A state of illness, say living with severe angina, might be rated as 0.5. The formula is simple: years of life multiplied by utility. If a treatment gives you 10 extra years of life in perfect health, that is 10 QALYs, 10x1. If a treatment gives you 10 extra years, but you are in pain and rated at 0.5 comma, that is only 5 QALYs, 10x 0.5. This allows us to compare apples and oranges. Once we have the QALYs, we look at the cost. This is cost-utility analysis. If drug A costs $10,000 and gives you 1 QALY, the ratio is $10,000 per QALY. If drug B costs $100,000 and gives you 1 QALY, the ratio is $100,000 per QALY. Drug A is clearly the better buy. Governments use this to set a threshold. They decide, we are willing to pay up to $50,000 for a QALY. Anything above that is too expensive, and we won't cover it. This brings objective logic to the budget. The most famous user of QALYs is the UK's National Institute for Health and Care Excellence, or NICE. NICE acts as the gatekeeper for the National Health Service. They review new drugs. If a pharmaceutical company releases a new cancer drug that costs £100,000 per QALY, NICE says no. They tell the company, lower the price or the NHS won't buy it. Because the NHS is the only buyer in town, the company usually lowers the price. This gives the UK massive negotiating leverage. It explains why drugs are so much cheaper in Europe than in the US. In the US, however, we have banned NICE-style rationing. The Affordable Care Act established a research body called PCORA, but explicitly forbade it from using QALYs to determine Medicare reimbursement. Why? Because of the disability critique. Disability rights advocates hate the QALY. They argue that it inherently devalues the lives of people with disabilities. Remember, the QALY math says that perfect health is 1.0. If you are in a wheelchair, your utility might be rated at 0.8. This means that saving your life is mathematically worth less than saving the life of a non-disabled person. 10 years of your life is only 8 QALYs. This is called double jeopardy. The disabled person is punished once by having the disability and punished again by the healthcare system because treating them is considered inefficient. Advocates argue this violates civil rights laws. They argue that a year of life for a person in a wheelchair is worth exactly the same as a year of life for an Olympian. The QALY fails to capture the intrinsic value of life, regardless of capacity. Because of this political backlash, Medicare is legally paralyzed from using cost-effectiveness to negotiate drug prices, though this is slowly changing with the Inflation Reduction Act. QALYs are also accused of ageism. Treating a 20-year-old yields more potential QALYs than treating a 70-year-old, simply because the 20-year-old has more years left to live. A strict QALY maximizer would always funnel resources to the young. Some ethicists defend this as the fair innings argument, the idea that the old have already had their turn and we should prioritize those who haven't. But seniors groups, like AARP, view this as discrimination. They argue that the healthcare system has a duty to the elderly precisely because they are vulnerable. Since the US government won't do this work, a private nonprofit called ICER, Institute for Clinical and Economic Review, has stepped into the void. ICER produces reports on drug pricing using QALYs and other metrics. Private insurance companies use these reports to shame pharma into lowering prices. ICER has tried to fix the disability problem by creating a new metric, the EVLYG, equal value of life years gained. This metric counts every year of life extension as 1.0 comma, regardless of the person's disability status. It ignores the quality penalty. This is an attempt to merge utilitarian efficiency with egalitarian fairness. Briefly, we should mention the DALY, Disability Adjusted Life Year. This is the inverse of the QALY. It is used by the WHO and World Bank. Instead of measuring health gained, it measures health lost. One DALY is one lost year of healthy life. The goal of global health policy is to minimize DALYs. This metric helps donors decide where to put their money. Should we fund malaria or HIV? They look at which disease causes the most DALYs. It is the utilitarian spreadsheet for the developing world. To conclude, in Lesson 4, metrics like QALYs and DALYs are not neutral math. They are moral judgments encoded in algebra. They determine whose life counts. The US has tried to avoid using them to prevent death panels, but the result is that we pay the highest prices in the world for drugs that often don't work. We are rationing by price instead of by effectiveness. In the final lesson of this module, we will look at the most extreme form of allocation, triage. What happens when the hospitals are full, the ventilators are gone, and the pandemic is raging? We will discuss crisis standards of care. For further reading, I recommend Peter Singer's famous essay, Why We Must Ration Healthcare, and Peter Ubel's work on the psychology of pricing life. These texts dig into the uncomfortable reality that we cannot escape putting a dollar value on human existence. Thank you.